I'd like to share with you a set of techniques that I've evolved for the treatment of patients with zonular deficiencies, both a method for distension of the capsular bag without hooks and a method for equalizing the force with insertion of capsular tension ring. Whenever doing cases where we have to suture to the sclera, I always place the scleral groove first. Here I make a 45-degree angle cut about 2 millimeters behind the limbus, and viscoelastic over the area of zonular dehiscence to prevent vitreous prolapse. The capsule is stained with trypan blue. Trypan blue is not just for dense white cataracts. It should be used in a case like this so that one can always visualize carefully the edge of the capsule in order to produce a precision capsulotomy. The placement of the capsulotomy is the key to this the success of this procedure. Here, Healon 5 is used to further tamponade the vitreous and also to flatten and stabilize the anterior capsular surface, which is inherently loose. You can see that when we puncture the capsule, there's plenty of resistance there to allow for a smooth transition from puncture to capsulorhexis. And as we pull around the capsulorhexis, we're watching very carefully to not go too close to the edge, but large enough so that we can take out the cataract. And when we come here to the edge, we have to be particularly careful because the cataract is flattened in this area and it'd be very easy to go over the edge, so to speak. So we keep the capsulorhexis small in that area. And you can see here, here we're placing Healon 5 into the capsular bag early on before we even do a hydrodissection, and it does some hydrodissection, but more than that, it distends and stabilizes the capsular bag, and again, without the use of hooks, we're able now to go in with the INA, bimanual INA handpiece, removing this rather soft cataract, and then periodically reinstilling Healon 5 into the capsular bag. You notice again that without hooks even, that the capsular bag stays distended despite this rather extensive area of zonular weakness from the Marfan syndrome. And again here, before we withdraw the irrigating cannula, we're going to instill Healon 5 again, and then again it almost looks like the capsule has normal zonular attachments in this area, again without hooks. The placement of the Healon 5 has to be, and here again we're placing Healon 5 over the area of vitreous exposure to prevent its prolapse. And you can see that we can do a very effective INA here because the highly cohesive nature of the Healon 5 prevents its expulsion from the capsular bag with the turbulent flow adjacent to it. And here the capsular tension ring is inserted. You notice the Sinskey hook holds the distal edge of the ring, therefore equalizing its force in the capsular bag and preventing asymmetric intracapsular forces which cause further zonular dehiscence. So the next step is to insert what Sam Maskett refers to as the deconstructed Sioni ring. This is an Ahmed segment, and we're going to place an bimanual ab-externo approach by placing a hypodermic needle through the ciliary sulcus and with the needle from inside with the polypropylene suture. Here we use 9O polypropylene, which has a greater stability. The Ahmed segment, model 6D, made by Morcher, is inserted and placed within the area of the large areas of zonular instability, and then tied. By using the scleral groove here rather than a flap, it obviates the need for the sclera to be sutured, and yet the suture itself is hidden inside. Because we have such a stable capsular bag, therefore we can place a one-piece lens within the capsular bag, and in this case, this young patient had opted for a multifocal lens, and this you can see here as the viscoelastic is removed by looking at the Purkinje images overlying the central area of the concentric rings of the multifocal intraocular lens is extremely well centered in the face of a pre-existing zonulopathy. Thank you.